Okay, since it's past 11, let me get started. My name is David Coe. I'm a neurologist, and then I did 3 years of epilepsy fellowship. So, as you may have gathered, if you do have epilepsy, you should, if you're still having seizures, see an epileptologist, a neurologist with more specialization in epilepsy. So I labeled this talk as new therapies because we're always looking towards the future of how can we improve patients with epilepsy with their epilepsy. So let me start with the present way of treating epilepsy is with medications. And we have nearly 30 different AEDs, anti-epileptic drugs. So it's almost impossible for one patient to have tried every drug because there's so many drugs. And in fact, amongst neurologists, some neurologists don't use certain drugs because they're not familiar with it. So when I finished my fellowship in '95, felbamate had just come out. There was no new drug since Depakote in '78. So I was lucky to be exposed to felbamate and used it. And but some of the newer neurologists, they never used it, so they're not familiar with it. So with medications, we have so many options, but most patients only get to experience a few drugs, and it starts with the physicians. The physicians hopefully are experienced, and they could offer all the medications to you, and we always look forward to new drugs once they get approved, like CBD was highly anticipated. But remember that if you've never tried a drug, it's new to you. So we have a plethora of drugs, and they all have their niche role, and hopefully if you're still having epilepsy, you get offered some of the newer drugs. And again, it's new if you've never tried it. So there's always hope because with medications, a lot of patients can be controlled. So at least 30 AEDs, especially with a few more coming up. But again, we always focus on the new, but if you've never tried it, it's new to you. So with the current medications that we have, how can we improve our performance in reducing seizures? So with lots of medications, there has been an effort to develop once-a-day formulations. So it's XR, extended release, or ER, another way to say. So certain medications like Depakote have ER, so it's once a day. Even levetiracetam Keppra, there's an ER formulation, which allows for once a day. There is also once a day lamotrigine, once a day oxcarbazepine, once a day topiramate. The reason once a day is important is that as creatures of habit, there is unfortunately circumstances where patients will miss a dose, and that's the most common trigger of seizures is missing a dose. So once a day improves compliance. The new term is called adherence, and if you are more adherent, then your levels won't drop, and hopefully you won't have a breakthrough seizure. So once a day formulations are available, and if they're generic, then there's no cost differential. Unfortunately, some of the once a days, like the topiramate and the oxcarb, are only branded, but the drug companies do try to be cost conscious, so they provide coupons, so if you have insurance, that the out-of-pocket costs are hopefully minimized. So once a day improves compliance, and that way we get maximum benefit of getting the medications and having adequate levels. So what about the new drugs that are in the pipeline, very close to approval? So again, CBD was the latest medication to come out, but it was only approved for Dravet and Lennox-Gastaut. But for those patients with that syndrome, there is another drug. So there's a new AD. It's called fenfluramine. And it'll also be approved for Dravet. So you'll have another option for patients with Dravet, and they're also looking to get this for Lennox-Gastaut. Now, for people with partial seizures, there are two drugs which are close to FDA review, and hopefully, if it's positive, it'll be approved. So there's a medication called Cenobate. Sorry about my bad handwriting, but I'm a doctor. And this will be through a drug company called SK. Cenobate has really good efficacy results in clinical studies. So as epileptologists and neurologists, we're very excited. Hopefully this medication will be approved soon. And another drug that's close, hopefully, is a medication called, actually I'm doing a lot of typos. This is a drug made by UCB, but Padacitinib. So hopefully this also will be approved as well. And the efficacy data looks very promising in that this drug was studied in refractory patients, so patients still having seizures. So this is very promising, and hopefully these three will be available soon. There are many other in the pipeline, but the pipeline's always tricky because a lot of drugs don't get approval because the FDA is very stringent, and if it's close, it's not good enough. It's got to actually meet statistical approval. So these are maintenance drugs. Now there's excitement in that there is new therapies for people who have what's called cluster seizures or repetitive seizures. So currently we only have a medication called Diastat, which is a rectal delivery. So it's not used that often in adults and kids. Some patients are able to use it if you have very frequent seizures that happen in a close period, called cluster repetitive. But there is FDA has approved a intranasal midazolam, so it's approved, so that will be coming out shortly. And I was walking through the exhibit. There is a medication that's delivered through an oral film called buccal delivery, and there's a study of that medication as a rescue or cluster medication. So hopefully that will get approved as well. And I was fortunate to be involved in, writing that protocol, going to the FDA, submitting the protocol for that. There's also an inhaled medication that can deliver medication in people who have cluster repetitive seizures. So only Diastat's currently available, but there is one that's FDA approved, the intranasal midazolam. So that will be an option for patients who have cluster. But the off-label use of that is some patients may have prolonged seizures or tend to go into status. So I've in the past prescribed Diastat for patients who have very frequent seizures, and let's say if they're going camping, they're in a remote area where medical access may not be readily available, or I've given to patients driving cross country with somebody. They're not driving themselves, but as a passenger, again, lots of the United States is remote, so there is a way to hopefully treat that seizure if it's prolonged or if the patient is clustering. Now, currently, the only treatment for seizure as it's happening is if you have a stimulator. So the VNS, vagus nerve stimulation, has been available since 1997. So it's a technology which is 22 years old. And the VNS has a way to activate the stimulator if you're having a seizure by using a magnet. Okay. So technology. So if you have a VNS, if you have an aura, you could activate the VNS with the magnet. But certain patients, they don't get much of an aura, or if the seizure happens in sleep, there's no way you're going to be able to use a magnet yourself, although other family members can activate the VNS with a magnet. But the latest iteration of the VNS has a heart rate monitor, and people with seizures will have increased heart rate, so it'll give extra stimulation automatically by itself. So currently, the only way to treat a seizure is to give yourself extra stimulation with a VNS. So VNS is, again, a 22-year-old technology. It's been widely used for both partial and primary generalized seizures. So the VNS is the first stimulator, and then we do have two other stimulators FDA approved for epilepsy. So there's one called the responsive neurostimulator. It's through NeuroPace. It's a little bit more involved than the VNS, but for patients that cannot have surgery or had surgery and still having seizures, this is an option. And then the latest stimulator, so the RNS does detect seizures because there's electrodes inside your brain, and when the device sees a seizure, it'll give stimulation. So it'll treat that seizure. The latest stimulator is the DBS, deep brain stimulator. So DBS has been available for Parkinson's disease and essential tremor for many years, so neurologists are very familiar with it, but the epilepsy approval only came last year. So we have 3 stimulators for epilepsy. So the rate of progress is accelerating very, very quickly. Now, this talk is supposed to have a Q&A, so let me finish with a new technology which can help epilepsy patients. But it's not a therapy. So Elon Musk, the person behind Tesla, is working on a car that could drive itself. So unfortunately, people with epilepsy, if you're still having seizures, you cannot drive yourself. But if Elon Musk perfects his self-driving car, patients with epilepsy will have more autonomy to be able to travel by themselves, because Tesla plans to offer Uber service, so there's no driver, unlike Uber, but you give the directions and it'll go to your destination. It's not there yet, although hopefully that will become available, so it'll help our patients with epilepsy. Now, Elon Musk is involved in Tesla. He's launching rockets into space, digging holes. He has one medical venture. It's called Neuralink. So Neuralink, he wants to do brain-computer interface. He wants to have chips inside the brain to interact with artificial intelligence. So he doesn't have a clinical purpose for his medical device company, but hopefully he can put his efforts into helping people with epilepsy. Hopefully this will be a stimulator which will also be helpful, not just for epilepsy, but potentially also for Alzheimer's. We have a great need for new therapy for Alzheimer's. A lot of people have memory problems with aging, and we do have some medications, but we need a novel approach. So that's why technology has been very promising, and I think we're living in a golden age, and things will improve. We'll have newer and newer therapies, and our choices are increasing ever. So I'm not going to talk about the detection devices that patients and families can use. Dr. Fisher, I believe, covered that yesterday. So I do want to allow some time for Q&A. So that was my brief presentation, and I'll take questions. Yes. Yeah, so EEG, the question is there any improvements on EEG? EEG is mainly read by an EEGer, so it takes a lot of expertise to read the EEG, but still it's done kind of manually. But with computers, we're able to do more computer analysis of the brain waves. So there's a lot of research in doing very high frequency activity, something in the gamma frequency. So, but those are done with intracranial studies because our scalp and skull filters out a lot of that high frequency activity. But in reality, the major advance was we have digital EEGs, so everything's computerized. So the days of paper EEGs, it's only for historical purposes. But the computers are somewhat useful in that we can do localization of sorts. So there is a technology called MEG, magnetic encephalography, in which that data is analyzed by computer analysis to hopefully see where that spike is coming from. So on EEG, we have a two-dimensional analysis of the brain activity, but with the computerized analysis, we could get a three-dimensional and then merge it with the MRI. But it takes a lot of work, so it's still more research, but progress is happening. MEG came out same time as MRI, but MRI is taken off. MRI has resolutions increased. It's like the digital pictures. When we first had digital cameras, we had maybe 4 megapixels, 6, 8, 10. Now we're up to like 24. If you're a professional photographer, you have like 50 megapixel pictures. So the MRIs keeps on improving. Yes.
Do you know if you have a VNS, if you're able to upgrade to the new version?
Yeah, so the question is if you have VNS and when you get the battery runs out, can you get the newer version? And depending upon the lead, most times you can. Unless you're the first generation model, then the leads may be a little bit different. But most patients, if you had it recently, you could get the latest ones with the automatic seizure detection. Yeah. So it's called the Aspire model of VNS. So it'll detect a heart rate increase and give extra stimulation when there's an increase in heart rate. But if you work out a lot, it may give extra stimulation, but the heart rate increase we could set at a certain threshold. So unless you're a sprinter, the heart rate with exercise goes up a little bit slowly. So, but with epilepsy, it goes up very quickly. So there may be some benefit of that extra stimulation by itself.
For the old model, there's no way to upgrade that?
No, you can. I mean, again, it's a 22-year-old technology, so if you had the 101, the first generation, that had different context, but the one with 106, you can, if you had the 105 or 104, then you could get, the newer ones. But if you have the first generation and the lead's not, then you could have a surgeon put the new lead, which is compatible with the, but it's backward compatible with prior models.
Talk about MEG in relation to MRI. The MRI doesn't pick it up, but MEG picks it up, for example.
So MEG is an extension of the EEG. It looks at the brain waves. The problem with MEG is that when we're using the technology, we want to capture a seizure to see where the seizure starts. So when you do an EEG, just as an outpatient, you're just getting interictal spikes. It's not a natural seizure, but they correlate pretty well. But for surgery, we have to be more precise and actually prove that area is where the seizure starts, because we don't want to proceed with surgery without proving where the seizure starts. Now, with the surface recordings, if there's a lesion, then we just have to prove that lesion correlates with the EEG. But if there's no lesion, then we have to do more studies like a PET scan. We have to put sometimes electrodes inside the brain. And depending upon which region of the brain, then we have to do mapping to make sure there's no critical function that we don't want to compromise with surgery. But that's why the stimulator device has been very exciting, because we have now 3 stimulators for epilepsy: VNS, RNS, and DBS. We still recommend surgery if you're not controlled, and surgery keeps on improving because our MRIs keeps on improving. The resolution keeps on improving. So every opportunity for me to get an MRI of my brain, I've had. So when I was an intern back in 1988, the hospital was installing an MRI. They wanted to try it out, so I volunteered. So I had an MRI then. And then I even had a 7 Tesla MRI of my brain, really high resolution. So because most MRIs are 1.5, and the academic centers now have 3 Tesla MRIs. 7 Tesla is, it's really strong magnetic fields. Yeah. Yes.
What is RNS and what is DBS?
So RNS is called responsive neurostimulation. It's a stimulator which is has electrodes near the seizure focus. So it's either a strip electrode or a depth electrode. And the device looks at that EEG, and when a seizure is detected, it'll give stimulation when a seizure occurs. So DBS is deep brain stimulation. So deep brain stimulation has been used for many years for Parkinson's and for essential tremor. But then Dr. Fisher, who was here yesterday, he thought it would be useful for people with epilepsy. So the studies were done, and deep brain stimulation is now approved for epilepsy. So for DBS, you don't have to know where the seizure starts. It just targets part of the brain called the thalamus. But for RNS, we need to localize where the seizures start and have the electrodes near that seizure focus. So the RNS may be applied for patients who, let's say, have a seizure, but starts, let's say, in the language area. We don't want to produce a language deficit from surgery, so you could stimulate, which is, again, temporary treatment for the seizures, but you're not resecting that area of the brain. So, but VNS has been around for 22 years. So in patients who are still having seizures, you know, these devices are options, and a lot of patients have offered it. But some patients, it's hard for them to, you know, take the plunge. But, you know, if you don't make a change, and if you're still uncontrolled, nothing's going to change if you don't make a change. And that's why I started to talk with the AEDs, because there's so many AEDs, and certain medications may give you more benefit than the current one. So if you're not controlled, you should be hopefully actively being managed. Now, before 2011, there was no guideline about how many AEDs you must have tried to say you're, you know, the chance of the new medication is going to help you. So as new medications were coming out, you know, we can't be trying everyone on every different medication. But so if you try 2 medications still having seizures, you are unfortunately have intractable epilepsy. Doesn't mean the treatment stops, but you gotta consider alternative treatments, which include, again, surgery. If you have a good lesion, it's amenable to surgery. There's a good chance of becoming seizure-free. So, and then if you can't get the surgery, then there are stimulation devices. There are adjunctive therapies like ketogenic diet, etc. So it's very important. It's in treating seizure. It's all or none. It's either you're seizure-free or you're not seizure-free. And again, if you're not seizure-free, you can't drive. So you know, we try our hardest to hopefully get there with certain medications. So certain medications like Feldmate, which I had prior experience using, it came out in '95, but if you weren't in that era, you know, a lot of physicians are not comfortable because they never used it. And certain medications may have potential bad side effects, but the key word is potential. So I offer often many different medications to patients, and a lot of patients will read about the potential side effects and not try it because of potential. The potential means it may not happen. So, but if you're still uncontrolled, then it's worth trying it, because if that medication is the best medication for you, then you hopefully don't have to proceed to surgery or devices. Yes.
Is felonate also known as Deltol?
Felbutol, yes.
So I have a question, because my son was initially put on that,
Mhm.
and then he was immediately taken off because they said that there was some potential liver issues that they hadn't had enough time on. So my question is, obviously it's been many years later.
All right.
What is, I'm going to call prognosis for Felbutol? It sounds like you're a fan of it. I mean, what do you think?
So it's like saying LeBron James is a basketball player. He's the best basketball player. There's other basketball players, but they're not as good as him generally. So Felbutol, when it came out, it did have problems. People passed away because of liver failure, but that can happen with Depakote, that can happen with Tegretol, that can happen with Dilantin. It can happen with a lot of medications, right? So it unfortunately it had problems, but was not taken off the market because people had really hard to control epilepsy. It helped more than any other medication ever did. So certain risk factors for developing that problem was that if you had autoimmune problems, you're higher risk. But it's been on the market ever since, and there hasn't been a issue since that initial year. So it was, again, the first drug since 78. So 78 and 95, no new drugs. So it was a wide usage. It was thought to be a manufacturing issue. The company that had it couldn't make enough. They opened a second plant, and it was a manufacturing issue. And it hasn't happened since, but in certain patients, it controls the seizures the best ever. Another medication that has a issue is a medication called vigabatrin. It can cause constriction of visual fields very slowly, but it's a very efficacious medication. So, but a lot of neurologists never were comfortable using it, but I've used it in certain patients and had very good response. So certain patients actually I was recommending VNS, but while waiting surgery, they would try these medications, and if they did really well, they never got the surgery because they were controlled. And it's just some patients have really good response. So the term that we use in medicine now is called personalized medicine, but knowing which medication is the best for that patient outside of genetic disorders, we're kind of in the blind. It's just trial and error. Again, the new genetic disorders, if you do have it, there are certain recommendations, like if you have Dravet, you should not get a sodium channel blocker. But for most epilepsies, unfortunately, there isn't a genetic cause. And as a prior talk was, TBI is a very common cause of seizures, traumatic brain injury. So epilepsy is very complex, but again, we're making incredible progress, but still there's no, quote, cure. And in terms of drugs, the options are ever increasing. So, but again, a lot of patients only tried a few drugs. So if you've never tried it, it's new to you. And if that's, there's a drug out there that could really help your epilepsy but hasn't been tried, then it's a missed opportunity. So, and again, if you have intractable epilepsy, seeing a community neurologist, they're not going to be very comfortable, or have even used some of the drugs that that are available, like, let's say, felbamate or vigabatrin. Yes. Yes.
Try and stay on medication instead of devices?
Yeah, so the devices are recommended for people who are very hard to control, that we can't control. So she's a patient of mine, and she's a very famous patient because she's the first patient to get the RNS, responsive neurostimulator. So if you have questions, you could talk to her, but she has done some patient outreach for people that are interested in RNS. So we tried to do surgery on her, but her surgical focus was in a motor area, so we will not do surgery to produce deficits. We won't impair motor, speech, and memory. So in certain patients, we can't do surgery. Then we offer VNS, RNS, and now we have DBS. So dose-stimulated devices are for people who, despite medications, aren't controlled. So often the medications still have to be used with the devices. So that's the realistic expectation. Now, certain patients do extremely well, but I don't say it happens that often where we can reduce the medications and take them off completely. So a lot of patients are adverse to medications. So the devices do not have medication side effects. They're not medications. The other benefit of devices is, as I was mentioning, the extended release formulations to improve adherence or compliance. The devices have 100% compliance because whatever we set it, it'll give stimulation at that rate. And then the VNS, with a magnet, we get bonus stimulation. And now with the heart rate stimulation detection, it gives extra stimulation when a seizure occurs. So in terms of acute treatment, the only two that treat the seizures as they're happening is the VNS with the heart rate detection, or if you're able to use a magnet, or if you have the RNS, which detects the seizure by brain waves and gives the stimulation. And then the rescue medications, which I mentioned, the inhaled one, is for people who have cluster, meaning they have one, and then 5 minutes later they have another, and then 5 minutes later or 10 minutes later they have another. So we're trying to prevent that next one. But it does not treat that seizure itself. So the devices are very useful because 100% compliance. And even the most obsessive compulsive person, it's hard to get 100% compliance on medications. We're human, especially if you have twice a day or 3 times a day medication regimen. It's hard to take medications and not miss any of your doses. That's why the XR and ER is something I really push, because when I've taken medications, like antibiotic, 4 times a day, after a week, I still had pills left over. You know, it's hard to follow directions, and so XR and ER, and then certain medications are once a day right off the bat. So niacinamide, perampanel, long half-lives, so it's once a day right off the bat. But certain ones, again, which I mentioned, like lamotrigine, Keppra, Oxcarb, topiramate, there are once-a-day formulations, XR and ERs. Yes.
For someone who's newly diagnosed and only had one grand mal seizure, lasted over 2 minutes, now is on Keppra, and after several MRIs and EEGs, they're saying I'm still having seizures, but they're not the grand mal like the first one. When do you stop increasing your medication if you're not having the grand mals? I do have migraines, but my concern is my body's going to get used to the Keppra, and we're going to continue to increase it if my EEGs are still abnormal.
So the epilepsy field is changed in that we now can define epilepsy after 1 seizure. Previously, you got to have had 2 unprovoked seizures. So in California, we have very strict driving laws. So I show many of my patients who are newly diagnosed when they're told they can't drive. Our Chief Justice, John Roberts, Supreme Court Justice, he's had 2 seizures in his lifetime, separated by 13 years. So technically, he meets the definition of epilepsy. So if you've had 1 seizure and you have an abnormal EEG or an abnormal MRI, which predisposes you to have possibly another seizure, you can now be called to have epilepsy. But if you're having smaller seizures, they're still seizures, although you may not clinically feel it. There are some seizures which are very subtle, and that makes seizures very hard to count sometimes. because a common seizure symptom could be a sense of deja vu. Now, does it mean every deja vu is a seizure? No. A lot of us had deja vu, but it's not a seizure. But if it's a seizure for you as somebody with epilepsy, that is a seizure. So if you're still having seizures, then you need to be treated, because we think that when you have lots of seizures, the seizure gets reinforced. It's called kindling. That's how we test new seizure medications, is stimulate a brain and then produce a seizure focus with electrical stimulation. So the new seizure medications often prevent that kindling. So kindling is an animal model of seizures, but there is unfortunately a human model of kindling that occurs in epilepsy. There's lots of seizures repetitively. But in people with severe depression, they actually get treated by inducing a seizure, ECT, electroconvulsive therapy. So psychiatrists use that for severe depression. Now, if you have migraines, it gets to be a little bit tricky, because migraines can produce neurologic symptoms, auras, and seizures also have auras. So sometimes it's hard to distinguish a migraine aura from an epilepsy aura. But luckily, 2 of our seizure medications are also approved for migraines, topiramate and Depakote, approved both for epilepsy and for migraine. Yes.
So a comment and a question. First off, going to all the medications and with Belvital and Morphelmate, I dealt with the same issue of I never went on it because of that liver issue and everything. But the comment being that no matter what's going on out there, one thing that I see happen a lot is people be, oh, has anyone been on this? And they won't go on because someone had a bad side effect to it. And the thing is, you have to remember, you're different than anyone else. So even if it didn't work for someone else, it doesn't mean it won't work for you. So just, it's a matter of keeping that in mind. And it took me 12 years and about 8 drugs to find the right cocktail. So don't give up.
Yeah,
Yeah, so don't give up. My question to you is, I know you're talking about all the stimulations and everything, and I know, like, I hear about the safety devices, and they're for the tonic-clonic seizures. Now, the stimulations, are they for any type of seizure, or just the tonic-clonic?
So the VNS was approved for partial seizures. They did a study for primary generalized, and the formal approval was for partial seizures. But it's been implanted in a lot of kids with primary generalized seizures. It works probably even better for primary generalized. So the standard practice is it's used for both. The RNS is only for partial, because you have to know when a seizure starts. DBS in the United States is a year old, so it's only for partial. That's what the study was done for. But, we'll see. Yes.
I have a question about the RNS, and I guess, about the implanted devices. You said there are no adverse effects, but could there be any rare digestive problems?
So the stimulators, so she's asking a question, are there any adverse effects from the stimulators? When the stimulators are off, there is nothing you feel. Now, with the VNS, you don't usually turn it on right after surgery, because it's wrapped around the vagus nerve, so your voice could be a little bit hoarse. So we let the people's recover, and then with stimulation, we set it so there's hopefully no discomfort, no change in voice. But if you're a professional speaker or singer, you could use the magnet taped over so it won't give you stimulation when it's on. And then in terms of stimulation, we always set it so there's hopefully no side effects. But the main thing is it's not a medication. There's no medication side effects. So the medications all have peaks and troughs, so we try to keep it so that you don't have any breakthrough seizures, but there's no medication effects from stimulators. They're not medications. And they have 100% compliance.
RNS? Nothing about the RNS?
So we set it so that you won't even feel anything. So we titrate from low stimulation up, but we always ask if there's any side effects. But we could ask the first patient with the RNS here.
I don't feel it.
Yeah, she was the first patient to get the RNS once it was approved. Yeah. Yeah. Okay, so I'll take one last question because I think we're running over time. Yes.
Is there any promising medication for gene therapies, such as like gene mutations, SQ1A?
Yeah, so I'm not a geneticist, so that's a little bit beyond me, but there is definitely some guides from the genetic epilepsies. Yeah. Yes. Well, thank you very much for your interest, and stay around for the next session.